Hi everybody. Today for our community education video, we're talking about the Maryland Molst form and the importance of medical interventions and when you need them and what the form's about, and talking about some pieces of that form. And I'm joined today by Rachel Sherman, who is a nurse practitioner with the Chesapeake Supportive Care. So Rachel, thanks for taking time today to talk with me about the Molst form.
Thank you for having me.
So let's start with a definition of that to begin with. The Maryland Molst, it stands for a medical order for life-sustaining treatment. Can you tell me what it is and why it's important?
So the Maryland Molst form, Molst is short for Maryland Order for Life-Sustaining Treatment. It's a portable medical order, meaning that it can be transferred from home to medical facilities, but it's an order regarding life-sustaining treatment and CPR.
Okay, so I'm going to jump in for a second. So if it's an order, then it's written by a physician or a nurse practitioner, so it's actually a medical piece that you have to have filled out by one of those, by a medical provider.
Correct. So the Maryland Molst form, in order for it to be fully executed and legal, has to be signed by a physician, a nurse practitioner, or a physician's assistant.
Okay.
And it's an order that must be honored by emergency medical personnel in the event of an emergency, or any and all healthcare professionals in any setting, whether that's a hospital, a nursing home, a dialysis center. And it really specifies what one's wishes are regarding CPR and other life-sustaining treatment.
Okay, so it's almost like that very first line. So if you have some sort of medical crisis and you call 911 like this, and you have the emergency medical service folks come out to you, this is like where that comes into play. Like this is, so something serious is happening. This is where that piece of medical order can come into play. That's correct?
Correct. So in general, the default is full code. If there is no Molst form available, the default is someone will be put through CPR in the event of a cardiac arrest. So this order really ensures, it's important because it ensures that medical professionals are aware of what someone's preferences are regarding life-sustaining treatment. So if someone does not want CPR and there's a Molst form in the home, emergency medical personnel and hospital personnel know that this is a person who did not wish to be put through CPR. And it also talks about other life-sustaining treatment. I always describe this when I have a conversation with my patients as you have the first page of the Molst form, and this is something that we generally don't have time to have a conversation about. In situations like cardiac arrest, this is an immediate decision that needs to be made.
Right.
And then on the second page, there are treatment options with regards to other life-limiting illnesses, where a conversation can and most likely will be had about whether or not we're going to give a blood transfusion or antibiotics or IVs or intubation. So it's important to know the difference, and the most immediate action is going to be taken on the front side of that form.
Got it. So it's like the emergency part, and then some of the other not so urgent pieces. Got it. So just to be clear, is there such a thing, and this is what I've heard of, a DNR, Do Not Resuscitate? Is this the same as that, or is that different? Like, how do those play together?
Yes. So a Do Not Resuscitate is an order that says, in the event of a cardiac arrest, I do not wish to be resuscitated. And there are a couple different levels. Maryland gives you a couple different options for your wishes regarding resuscitation. But essentially, Do Not Resuscitate means do not provide chest compressions in the event of a cardiac arrest. And there's some different layers that say, do not intubate me, you can intubate me, or make sure that I'm comfortable. So
but is that the same as having the Molst, or are those pieces a part of the Molst, or is a DNR a totally separate form?
No, so the DNR is a part of the Molst.
Gotcha. Okay.
The Molst form identifies your wishes regarding the type of resuscitation, and
Okay.
Do Not Resuscitate is a type of resuscitation.
Got it. Okay. So I want to break down, if we could, because I've looked at the Maryland Molst form, and it is, pretty heavy on the whole medical language piece. So if the common person is just reading it, it's got some confusing pieces, which is why it should you go over it with your medical provider. If we could start with that first piece about CPR. And if you could break that down for me, maybe give a case situation, how that looks for a 40-year-old versus an 80-year-old, to kind of look at that first option.
Absolutely. And you're absolutely correct in saying that it is a complex form to understand. And that's why it's really important to have this conversation with your medical professional. And it's not a quick conversation to have. Because there are a lot of scenarios surrounding this, and CPR looks different, just as you alluded to. It looks different for someone who is younger versus someone who is older versus someone who's relatively healthy versus someone who has chronic medical conditions. So I always give the example of, you have a 20 or 30-year-old patient who has a cardiac arrest because of some event. Maybe it could be a medication reaction. It could be a respiratory disorder. CPR in those cases, are more likely to be successful when you compare it to someone who is older, who has comorbidities. So CPR involves chest compressions and intubation. It involves the administration of significant or high-level medications. It involves potential transfer to high-level care, including the ICU. For patients who are in their 30s and in their 40s, we know things like their bone structure. It's a little more flexible. Now, not as flexible as it was when you were 5 or 6, but it's a little more flexible than if you were 60, 70, or 80. So one of the biggest risks associated with CPR for someone who's above age 60, 65 is the risk of fractures, rib fractures, because there is no light form of CPR. These are significant chest compressions. There's always the risk to damage to internal organs. And that looks different when you're looking at a patient who's younger versus a patient who's older. You look at a patient who has cardiac disease, maybe they have atherosclerotic arteries, maybe they've had a heart attack before, they've had a stroke, they have high blood pressure or cardiomyopathy, enlargement of the heart. The chances of CPR being successful in that person are a lot less because they already have some damage or low level functioning of that organ already. And then we look at the options or the ability for recovery. So the longer that a person goes without spontaneous circulation, you run the risk of having reduced oxygenation to the brain, reduced oxygenation to other vital organs like the kidney, the liver. And to what degree those organs can recover after having a cardiac arrest does have some correlation with the age and their comorbidity. So for resuscitation, it is a conversation that really has to be had in the here and now. Where is your health status now? What's the likelihood that you would recover? And also, what would you be happy with for a recovery level? Would you be okay with remaining on machines for the rest of your life? Or feeding tubes, not being able to interact with your surroundings, or having some low level of debility.
Wow. So that is super involved. I mean, that is like that you can't get that from looking at the form. First of all, you can't really understand the depth of the repercussions of having an intervention like that. So there are some really significant thoughts that you need to kind of think through and have that conversation.
And it's highly individualized.
Right.
Highly individualized.
Right.
It just depends on where you are. A lot of people have this notion that CPR is what we see on TV, right? They shock you back. And I've even heard people describe that. Though of course I want to be shocked back. But in the setting of CPR, not every patient gets a shock, a cardioversion or defibrillation. It's completely different than what it's portrayed on TV, and it is significant.
Right. So also on this form, on the Maryland Molst form, there's, besides CPR, there's the artificial ventilation. And I think because of COVID, we've heard about that piece a lot more than prior years. But can you kind of sort of talk about what that option looks like? Because it's as I said, it's been talked about more, but maybe not explained so much. If you could cover what that menu option is.
Absolutely. So The Maryland Molst form gives two options for comprehensive efforts to prevent arrest. So you have full code, which means full resuscitation, and then you have the no CPR option A. So you have option A1, which means comprehensive efforts will be made prior to the cardiac arrest, including intubation. That means having a breathing tube placed down into the lungs, being placed on a machine called a ventilator to provide breathing efforts for you. That also includes the administration of medications to stabilize you, whether that's medications to try and attempt to restart the heart, medications to try to maintain blood pressure, medications to correct electrolyte imbalances. So these are all the things that you'll receive with an option A1. The only thing that is not provided is actual chest compressions in the event that the heart stops. So if the heart stops, they will allow death to occur naturally.
Okay.
There's an option A2, which is the do not intubate. And that again means comprehensive efforts will be made prior to the arrest, including the administration of medications. But instead of being actually intubated and having a tube placed down into the lungs, they'll use something called a CPAP or a BiPAP. And in some hospital settings, that can be an entire face mask that kind of forces air to keep the airway open. It can be a mask that goes just over the nose and mouth, and some hospitals even have the mask that just goes over the nose. And these are to try to turn around issues related to respiratory decline, a really bad pneumonia. You've had a respiratory arrest because maybe you had a medication that compromised your airway. But again, if your heart were to stop at that point in time, they would not do chest compressions and they would allow death to occur naturally.
So it's like this almost sliding scale or gradated, like there's a lot of intervention, there's a little bit of intervention, and then there's a little bit less. So just sort of, okay. So just being aware of that and kind of going in to be able to talk to your medical provider, having that thought in your head, like how much, where am I in my health status? Where am I in my age? Where am I in my quality of life right now? And then keeping that in mind, having the conversation and asking your medical provider to help you understand these outcomes, right? Like, what does that mean? Because that's, it sounds like, Rachel, the other part of it is really, all right, you get these interventions, what does it look like afterwards? And that can depend on a person's health.
Absolutely.
Okay.
Absolutely. And the way that this form is situated, when you actually look at the Maryland Molst form, the order of interventions go from highest in severity or highest level to lowest level. I think it's very, very, very important to note for some patients that if you decide that you do not want to have resuscitation, that does not mean that your medical team will stop treating you. The only time your DNR is enacted is in the event of cardiac arrest. So if you're in the hospital because you're having heart issues or you're having breathing issues, all the attempts, and as long as that's what you want to improve your status, will continue to go on. They'll treat your pain, they'll make sure you're comfortable, they'll treat your anxiety, treat your infection. Only in the event of a cardiac arrest will these orders be initiated, and they will not put you through CPR.
Got it. Got it. That's really important to know, because I'm sure you read these things and it's a little scary. Like, I don't know if I want to make that decision. And I think the other piece that we've talked about before is making sure this isn't just a one and done conversation. This is a constant, like, how often would you recommend someone have that conversation with their provider?
So, that varies again. So I always recommend that annually patients are having this conversation with their medical provider. The gold standard, or what we would like to see in the ideal world, is that when you come in for your annual physical, this is something that's included in your annual physical. We should review this and make sure your wishes are still the same. Because just as you mentioned, my wishes at age 40 are going to look completely different from my wishes at age 80 or 90. They're going to change. Right. And if I become ill, my wishes may change in that moment as well. So Really, you're gonna examine your wishes at least annually, but you're also going to examine your wishes when there's a change in your condition. If you've been hospitalized, if there's been a change in your health status, if there's been progression of your cancer, um, if you're now seeing or moving into a more advanced stage of your illness. So are we more in an advanced stage of liver failure? Are we in more of an advanced stage of dementia, or kidney failure or heart disease? So these are revolving conversations, and they could change from day to day. I tell this to my patients who are hospitalized. I could have a conversation with you when you're admitted, and then that conversation may change 3 and 4 days later as we know the full picture of what's actually happening with your health.
So it's important to keep that in your mind, to keep that as things change, or as, that annually could be the minimum depending on the situation, but at least to keep that in mind. Okay.
And any change in your level of care. So if you are living in the community and you're living independently,
Mm-hmm.
your most may look one way. And then say you go to the hospital and your most may look completely different because the clinical situation looks different. And then you improve and maybe you go off to rehab. At each step, each change in your location, you really should have your most reviewed. Your medical provider should talk with you about your wishes and what resuscitation would look like at your current state.
So just in a situation like that, I'm visualizing there's a lot of players from a medical care provider perspective. Is there one particular point person that you would recommend be the point of contact for a patient to advocate for themselves to?
Yes. So, that's one of the beautiful things about palliative care in the inpatient and the outpatient setting. That's what we specialize in. In palliative care or supportive care, we really specialize in looking at the patient as a whole, talking with them about what's most important to them at that point in time, and documenting those things and sharing it with the team. If palliative care is not available, these are conversations we're going to encourage patients to have with their family members, maybe the person they've identified to make medical decisions on their behalf.
Okay.
And really, when you're admitted to a facility, the onus is really on the admitting medical provider or medical team to make sure that they have addressed this. So if you're in the hospital, that's going to be your primary or attending team. If you go to a nursing home, that's going to be your admitting or covering physician. If you come home, then it should be your primary care doctor or the specialist that's treating you.
Okay. That's good to know, because those are different people in every situation. So it's like, okay, well, who should I talk to? In just the interest of time, I'm going to jump to the whole where does one access a Molst form, and sort of how do you download one? And if you have specific, when you're speaking to your patients, are there any resources that you share?
So I always recommend that patients can get a copy of the Molst form from their medical provider. If you're in the hospital, this is a pretty standard form. If you go into just about any medical facility and you mention the Molst form, they're going to know what it is. If you're in the home setting, Maryland actually has a pretty good website called marylandmolst.org, where you can go and you can download the actual order form. And you can also download the instructions for that form just to read through. I often tell patients, if this is a conversation that we're going to have, we may not accomplish the full conversation in one setting, but I'll give them a copy of the Molst form and I'll tell them, read it over with your family, mark it up, write down questions. And then when we come back to have that conversation, we can address all of your concerns or questions. So definitely visiting the Maryland Molst website has some information for clinicians and patients. And then a lot of those questions should really be geared towards your medical provider.
When you review the Molst form with a patient, how long does that usually take? If you're sitting down and that's all you're focusing on is completing that form, about how long is your appointment?
At a minimum, it's about a 45-minute conversation. Because there are a lot of questions, there could be a lot of anxiety or fear, and there could be a lot unknown. Right. A lot of people tend to think, if I say I don't want to be resuscitated, they're not going to treat me. They're not going to try to stabilize me. And we have to dispel that. And then we really have to talk about what's most important, because a lot of this is what if scenarios. What if you can't swallow or eat the traditional way? what if your kidneys fail, right? And it may not be happening to them right now. So these are a lot of scenarios where they have to envision themselves in a situation that they're not currently facing.
That's not fun. That's not a fun thing to sit there and think about, right?
And it's even longer when we're having this conversation with family members. Because if you could think or put yourself in the shoes of a parent, as a mom, if I were older and my children were adults, I may be fearful to really express my wishes because I don't want to upset my children, or I don't want them to feel a certain way based on my decisions. So sometimes those conversations really explore a lot of the emotional distress behind it, or the emotions that go into it. So anywhere from about 45 minutes to maybe up to 2 hours to maybe up to 2 to 3 visits.
Right. Yeah. It sounds like it could be something that would take multiple, like you do it little pieces at a time, because it does sound, it's very emotional and can be overwhelming. Well, I know we didn't dive into the whole thing. The form is intense, and it's as you've said, and it makes sense. It's very personal, and it's needs to be addressed by a medical provider with their patient and really diced individually for what that person needs. But I appreciate, and I'm sure appreciate you taking some time to try and help break down some of the information with it.
Absolutely. You know, I would say the take-home message here is, for most patients, if not all, the most important side of the form, the here and now, is to really talk about your wishes regarding resuscitation, because that's not something we're generally going to be able to have a conversation about if we're in that situation. It's either an act now or an act now. You know, we have to, that's the immediate. And then some of the things on the back, again, they may not be things that are relative right now, but they're good things to know, because if you get into a situation where you're really sick and you can't speak for yourself, well, this form can speak for you. But then also it gives you the opportunity to open up that conversation with your family members or your loved ones and say what's most important to you, so they at least know how to act on your behalf if they have to speak for you.
Right. Right. And I think a lot of people don't necessarily know about the back part, that there are so many options. Like, it isn't just CPR. There are other elements that are now available for medical intervention. So it is really good to know, just to be familiar with what your options are.
Absolutely.
All right. Thanks, Rachel.
All right, thank you.
I also want to thank the John and Kathy Belcher Institute for their generous support of the community education programs at Hospice of the Chesapeake.